Hello, this is Kim Jong-il. In today's lecture, we will look at a case of non-extraction treatment by using mini-screws. Case 1 is a case of lower anterior crowding, with crown labial inclination on the lower incisor. This case was treated with non-extraction by uprighting the labially inclined crown of the lower incisor by using mini-screws on the maxilla and class 3 elastics. This patient's CC was mandibular anterior crowding. The upper and lower lips show slight protrusion, but the face has a round shape. If we look at the maxilla and mandible, the third molar is either erupted or impacted. The left and right canine key is class 1. Let's look at the PA view. The right side is relatively short. When viewed from the front, it doesn't look too bad. There is some crowding in the mandibular anterior region. We can observe bony exostosis in the mandibular dental arch. The dental crown is palatally inclined on the right side of the maxilla. Only 2 mandibular central incisors are labially inclined. If there is no crowding in the canine and premolar regions, and if we can arrange mandibular incisors with labially inclined crowns into the dental arch, we can attempt treatment without extraction. The canine relationship is class 1. The crown of the maxillary premolars are palatally inclined. Although neither the maxillary TPW or intercanine width are narrow, the maxillary premolars are slightly palatally inclined. Let's look at this patient's ODI, APDI, and CF. The ANS is located downwards. The palatal plane angle has a positive value. The ODI is 76.5. The A point is located towards the front. The AB plane angle has a negative value. The APDI is 83. The CF value is large with 159.5. This is a case of class 1 low angle. The mouth is slightly protruding, but the face is round. The UOP of 9 degrees and POP of 12 degrees are normal, and the U1 to FH of 116 degrees is also normal. However, we can see that the mandibular incisors are heavily labially inclined with the L1 to MP, or IMPA value of 118 degrees. This makes the IIA a small value of 104 degrees. Therefore, the mouth is slightly protruded. Many people may think that the premolar must be extracted due to the big IMPA and small IIA. Let's look at the list of this patient's practical problems. 1. Protrusive lip suggests extraction. 2. Moderate crowding suggests extraction. 3. A large combination factor suggests non-extraction. 4. Bony exostosis suggests non-extraction. 5. Labioversion in the mandibular incisor and small IIA suggests extraction. The problem with non-extraction treatment in this case is the protrusive lip. The labioversion in the mandibular incisor and the small IIA 101 degrees are also not desirable. If we perform extraction on this patient, the mouth protrusion may be resolved, but the combination factor is large at 160. Therefore, the currently normal maxillary incisal angle U1 to FH 116 degrees would worsen. What does this mean? The deep overbite will become more severe, and it could be difficult to fill the space created from the extraction. Both non-extraction and extraction treatments have downsides. In these cases, I also have dilemmas. After explaining the asymmetry, there will be two possible treatment plans, either extracting only the third molar or 4 premolars. We must discuss with the patient the advantages and disadvantages of both methods, with extra emphasis on the disadvantages. The major issue with extracting only the third molar is that the shape of the face will not change. However, the patient's CC is not aesthetic. The guardian also doesn't have a problem with the patient's current profile. The issue with extracting 4 first premolars is that the wisdom teeth will also have to be extracted. So a total of 8 teeth would have to be extracted, and excessive space may be created after extraction. Moreover, the mouth may further retrude. Female patients tend to prefer retrusion, but male patients of low angle type such as this one tend to be satisfied with their current appearance. So I decided to treat this patient by extracting only the third molar. The possible treatment methods are as follows. First option, strategic leveling followed by maxillary and mandibular mio and short class 2 elastics. Second option, total retraction of the maxillary and mandibular dentition by implanting mini screws on the maxilla and mandible. Third option, moving the anterior dentition backward by using mini screws on the maxilla and mio and elastics on the mandible. How would the teeth move in the first option when we apply maxillary and mandibular mio and short class 2 elastics? The mandibular molars are not mesially angulated. In other words, the POP is normal at 12 degrees. There is labioversion only at the mandibular incisors. If we use maxillary and mandibular mio and short class 2 elastics in such cases, there will be further labioversion in the mandibular incisors. Labioversion of the mandibular incisors results in an unaesthetic face. Even if the patient is satisfied with the current appearance, unaesthetic appearances due to labioversion of the mandibular incisors are not desirable. If we choose the second option, we can perform total arch retraction by using mini screws on the left and right sides of the maxillary tooth under 5 and under 6, and the mandibular tooth under 5 and under 6. The biggest issue with this option is that the maxillary and mandibular tooth under 7 will move out of the dental arch and move slightly buccally. We can see the mesial inrotation of the mandibular second molar in the photo. For the third option, to prevent buccal movement of the mandibular second molar, we can use mio at the mandible and mini screws in the maxilla with class degrees elastics. We chose the second option and performed total retraction by using mini screws on the maxilla and the mandible. An open coil spring would be used around the mandibular tooth number 6 during strategic leveling. The mandibular and maxillary teeth would have been arranged. We can insert mini screws between tooth number 5 and number 6 in both the maxilla and the mandible, and use a power chain from the mini screws to the maxillary canine, mandibular canine, or premolar to perform total retraction of the mandibular dentition. However, the left mandibular mini screw fell out. The mio was originally planned to be used last after the total retraction of the mandible. But since the mini screw fell out, the plan changed to use mio earlier. A 0.00160.022 SS arch wire was inserted in the maxilla, and the maxillary dentition was moved backwards. We then engaged the mio-W arch wire on the mandible. After engagement, 5/16 6 O's class 3 elastics were applied from the maxillary mini screws to the mandibular mio. What would happen next? The mandibular anterior dentition moves backwards. Because we can apply crown-lingual torque on the mandibular molar with Mio, the mandibular molars can move backward within the dental arch. After the mandibular incisor has been somewhat uprighted, we engaged Mio on the maxilla. The maxillary wire was changed to Mio, and anterior vertical elastics were used to tighten the occlusion. This is how the treatment was completed. The crowding in the mandibular anterior region is resolved. Class 1 canine key is achieved, and the front, side views are all decent. By extracting the maxillary and mandibular third molar, we were able to move the maxillary and mandibular dentition backwards to obtain space. Let's look at the PA view. The patient can close his mouth more easily. One of the big problems with using mini screws is the decrease in vertical dimension. By applying Mio on the mandible, it was possible to move the anterior dentition backward while maintaining the vertical dimension. The treatment took 1 year and 4 months. What should be noted is that the combination factor never changes. As you can see, the CF didn't change from 160. Let's look at the mandibular L1 to MP, or IMPA. The original value of 117 degrees has improved to 112 degrees. The mandibular incisor with labioversion has been easily uprighted by the force of the class 3 elastics. This is the superimposition of the CEF before and after treatment. We can move the molars backwards to obtain space while minimizing labioversion of the mandibular incisors. I have mentioned this already, but if we use the maxillary mini screws with the mandibular Mio, we can maintain or increase vertical dimension and move the mandibular dentition backwards. Let us compare the profiles before and after treatment. After treatment, the lips are sealed more easily. They were slightly protruded before treatment, but they are significantly better after treatment. How is this possible? Because the combination factor was big. If this patient had a small combination factor, we would have had to extract the premolars. For cases with a big combination factor, unless there is severe crowding, we can move the molars backwards to obtain space. If there is a possibility of labioversion of the mandibular incisors due to force vector, we can use mini screws. This is the profile and the frontal view before treatment. Let's look at the overall treatment process of the mandible. Strategic leveling. The red boundary shows the backward movement of the mandibular total dentition. However, there is a limit to moving the mandibular total dentition by using mini screws. This can be done more easily if we use the mandibular Mio and class 3 elastics together. One of the biggest reasons for using Mio is that it can rotate parallel the mesial in-rotated mandibular second molar. This makes it much easier to get the arch form. We can use Mio to move the total dentition backward. For cases of class 2 or 1, the mandibular incisors may experience labioversion due to the use of elastics. I use maxillary and mandibular Mio when the mandibular incisors are normal. However, for cases such as this, the labioversion of the mandibular incisors will be worsened if we use mandibular and maxillary Mio and class 2 elastics. This is not only prone to recurrence but is also unaesthetic. Mini screws can also be used to move the total dentition backward. If we only use mini screws, the mandibular second molar is inevitably moved buccally, which may result in posterior crossbite and/or tapered arch form. To prevent this, we can simultaneously use mini screws on the maxilla, Mio, and class 3 elastics on the mandible to move the maxillary and mandibular dentition backwards. At this time, the premolar region can be extruded like this to maintain the vertical dimension. It is possible to use mini screws and mio together like this to obtain space. Thank you for watching.